Alex.
Do you know how I get into the presenter view? Is that a thing I can?
It kind of looks like you're there already. Do you?
Oh,
You're already there, Mom. You're good.
okay, cool.
Perfect.
I hear something, some little creature.
It's probably my cat. She's.
Oh yeah, I hear it.
She's
Yeah,
right
okay.
behind you.
My German Shepherd's right here, and if anybody walks by, I'm gonna have to mute myself immediately.
Immediately, we know.
Yes.
We know.
As my neighbor said, he has quite a bark on him.
I tried to kick her out, and that was even louder.
Yeah.
And so, Molly, if you can just stop sharing for a while, we're gonna do some introductions, and then I'll get you started. I'm so excited. Welcome.
Yeah,
Welcome. Hi, Dr. Aurora. Thank you for coming.
16. So we had 16 people. How many were we gonna have in the 20s? Maybe I'm guessing
Yes,
usually.
I think about like 26, 27.
Okay, well it's exactly
I
noon.
think some are going to come to
9.
presentation versus others, so we can start whenever you.
Okay. All right. Well, I'll just get started. Just to, I guess we're supposed to always read that CME thing, which I always forget to do. So let's be official.
It's
Why
okay. You
not?
turn it over to Alex, and he'll go through it for you.
Oh, okay, perfect. So, well then, yeah. Welcome to the UNM Rural Department Spring Conference. I know the PMANM, which is a mouthful's names all over it, but that's because we sponsor it. Really, it's all of their work. And Angela, was just speaking, is the one who's doing all the work for this, most of it. And we have our own in the fall, but we have a long history of sponsoring their spring conference. There's a lot of things that UNM, being a state institution, is allowed to pay for or not pay for. It gets grants for certain things and other things. So we kind of step in, and we can't really put 2 conferences a year on, but we can do 1.5. So it works out real well. And as much as Zoom is not the same as being in real life, it is nice because we can do these things for free, not just for members, but for everybody. And we're at 3 hours, which seems to be the perfect time for getting enough CMEs, but making it livable. Let's put it that way. Before we get started, though, we do want to recognize somebody who's on this call, Dr. Bagwell. And Dr. Bagwell, hey, hold on a second. Is here. He's with the New Mexico Department of Health, and he serves as the Forensic Division Director of the New Mexico Behavioral Health NMBHI at Las Vegas. And they have a program that provides residents an excellent opportunity to rotate through the inpatient psychiatry units at both the adult psychiatric services and forensic divisions. So we just wanted to give him a shout out and appreciate his work.
Yes, sir. Thank you very much.
Sure. And
one second, Nick. Dr. Bagwell, if you guys don't know, and some people may not be from New Mexico, but we have had 1 and 2 of our largest fires here in New Mexico in the sister state's existence, and some of those fires have actually affected Las Vegas, has affected the hospital. And so I wanted to give Dr. Bagwell just some few moments to talk a little bit about the hospital, talk a little bit about the updates, and if there's any way that us in this community can help him, his family, the clients, the patients there in their own community. So just a little bit from Dr. Bagwell.
Yes, ma'am. Good morning to the group, and please call me Paul. This is my 21st year here at the State Hospital, New Mexico Behavioral Health Institute. Humbled and thank you guys for inviting me to this opportunity. What a great opportunity. Just real quick with regards to the residency program there at UNM has been super. I've been working with all the way back for years. Dr. Silverblatt and others. Again, the residents have come to the state hospital. They've rotated through. They're excellent group, top notch. What we've been doing is allowing opportunity for psychiatry residents to get some additional exposure in the psychometrics. Granted, in the forensic inpatient units here at the facility, also get an opportunity for report writing opportunities, get chances to view. This, of course, was pre-COVID, direct opportunity to watch, testimony and competency hearings and that type of thing. So, and then of course the basic staples with regards to treatment guardianship hearings and that type of thing. So that's all been made available, and we continue to support UNM Psychiatry Residency Program here. Recently, we had a change in the clinical director, the leadership and chief of psychiatry, and Dr. Andrew Keys is our psychiatry chief. Excellent gentleman. If you don't know him, long and short of it is we've been working collectively, and now we're trying to develop and cultivate, of course, the programming for residents to rotate through the non-forensic, the civil side, if you will, of the state hospital. So we continue to, support you guys in any way that we certainly can to get some additional, exposure to the inpatient populations that we have here at the state hospital. State hospital, real quick, of course, comprised of 5 divisions. Forensic is just one. The civil side is the second one. We have a long-term care, we have outpatient, and then we have a child adolescent program. So that's just a real quick run through. Like Angela mentioned, the natural disaster related to the fires was unprecedented. I won't take too much of your time, but that all dropped. I got the call about 1:30, 2 o'clock in the morning that we were going to evacuate the entire hospital. At that time, my census at forensic was about 75 people. Essentially, we, through all different entities and people through state police, etc., we transported the gentleman to a Guadalupe County Detention Center, and the ladies we transported over to Santa Fe County Jail. Our folks are all pre-trial under the auspices of Department of Health as opposed to Corrections Department, but we were working with Disability Rights New Mexico, keeping them apprised of all that we were doing. And fortunately, it was time limited, and we were all back home here at the state hospital where I'm calling you from this morning on the 18th of May. So roughly 2 weeks, and it was quite something. That morning when we departed, you could literally feel the ash falling and hitting you on the back of the neck and on the back of the head, and the smoke was just, it was something else. So again, thank you guys very much for inviting me. I really appreciate the opportunity. And once again, representing both forensic and APD side, and NMBHI for that matter, will continue to support the UNM residency program. Thank you guys very much.
Thanks so much. Yay. And I guess, Dr. Whitt, if you want to start sharing, I'll start talking, and by the time I'm done, you will have your presentation up. So our general program is on TAY, Transitional Age Youth. That is a topic that there was some interest in it based on a survey we sent out to our membership. A lot of times when we talk to the rural health folks, we'll go back and forth if it's something that we found our folks were interested in, or maybe they were, so long as we come up with something that seems useful. And then someone had this great idea of having the residents speak, and maybe we could give a prize and have them give presentations. And all of a sudden it kind of morphed into, let's do all residents and really showcase them. And I think it's good for 2 reasons. One, it gives them a chance to shine. It gives them experience doing this sort of thing, but also they are on the leading edge of learning all the newest things. And so for those of you who are been in practice a while, it maybe, actually learn something new today. So our first person is Dr. Molly Wit, and she is a New Mexican raised in Edgewood. And she stayed in New Mexico, went through her undergrad and medical school here. She is a 2nd-year psychiatry resident. She is also on our board as a RFM, resident fellow member at the Psychiatric Medical Association of New Mexico. And she has always been interested in LGBTQ plus patients and works closely with local medical providers and outreach organizations to improve quality of care for transgender and gender non-conforming patients. And before I turn it over to her, real quick, what I just read and her program and a lot of really great stuff, Angela has dropped in the chat. And so there's going to be a lot of things in the chat. And when we get to the CME stuff as well, Alexander Pond will talk to you. And I have a feeling he'll be dropping stuff in the chat. So keep looking in the chat for things. Oh, one last thing. If you have a question and you don't want to speak at the end, if you drop it in the chat, I'll read through them. That's it. Go ahead.
Awesome. Thank you so much, Nick. I really appreciate that. And just making sure everyone can hear me all right.
Yes.
Good deal. All right, so I'll be talking about best practices for treating transgender and gender non-conforming patients. This is like an area of interest that I have found that some people folks either know quite a bit about it or they don't know anything at all. And so I'm really kind of happy to be able to share some information with you and hopefully be able to answer any questions or maybe help clarify some terms. So as Nick mentioned, these are our sponsors. Thank you to the Behavioral Health Collaborative and Psychiatric Medical Association in New Mexico for letting us talk today. We can come back to this slide because this is for CMEs. My disclosures, I don't have any financial arrangements related to this. And a disclaimer that these are my own opinions. This is my own material. It is not necessarily the opinions or policy views of University of New Mexico. And now I was hitting the wrong key. I do like to acknowledge the land that UNM does sit on. This is the traditional lands of the Pueblo of Sandia and the original peoples of New Mexico. We acknowledge and our committed relationship to them and to gratefully recognize our history. So the learning objectives for this talk, I'm going to talk about defining and describing gender identity, gender assigned at birth, sexual orientation, and gender expression. We'll go through the DSM criteria for gender dysphoria and disorders of sexual development, and also talk about the controversies and challenges associated with those diagnoses. And then finally, we'll summarize the best practices for engagement with transgender and gender non-conforming folks. Excuse me. So some considerations as we go into this talk. I am cisgender, identifies female, identifies heterosexual. So I'm not actually particularly a part of the community that I'm going to be presenting on. That has some downsides in that I am presenting about a community, like I said, that I'm not a participant in. But the upside to this, I think, is that really no questions are inappropriate. Please ask me as many questions as you would like. I will not consider them gauche or offensive. I will not personally be offended. And I want this to be a space where even if you've always had a question, but you're kind of afraid to ask, this can be a place where you can ask that. Folks have studied gender and sexuality throughout careers. This is one view of the best practices, and standards of care in this population are still in infancy. So recognizing that there's still a lot of research needed in all of these areas. So what is gender? Typically, when we talk about gender, it's one word that we're using to talk about identity, expression, sex as far as genetic sex, and also gender assigned at birth. It's one term that encompasses a lot. So first we'll talk about identity. What is identity? Identity is a person's basic internal sense of being a man, a woman, or another gender, or non-conforming and just not in that binary at all. We can think of gender identity on a spectrum, and between womanness and manness, maleness and femaleness. and people can exhibit and identify with various parts of this at various times. Some gender identity terms here. Excuse me. Gender fluid is
start some conference.
oh, Ashwini, hello. So gender fluid is a term about maybe not feeling one way or another, or feeling more masculine one day, more feminine another day, just kind of more in touch with how someone's identity might be changing in a time or space. Non-binary is, I don't think this man and female, male-female part is, I don't think that's all there is. I'm something completely different. Transgender is recognizing there are two genders, male and female. I was born as one and assigned as one, and I identify as a different one. I'm having to move my little boxes around. Gender queer, more of an umbrella term. Intersex, we'll talk about that moving forward, and that has to do with both identity and a sexual, like sex assigned at birth and external, internal sex markers. And then agender is just, I'm opting out of the whole gender identity entirely, and that is how I identify. Next part is expression. Expression is typically conveyed. This is what we see as clinicians. It's conveyed through appearance, behavior, and personality styles. It's culturally masculine or feminine, but again, I would say that it is really on a spectrum. Here you can kind of get an idea of expression as far as, some days looking more masculine. Sort of, there's things like butch style, which are more masculine and male looking. There can be more feminine expression, skirts, flowers, the color pink are all more associated with femininity in our culture. But people are doing more and more just sort of mixing and matching and what am I expressing and what do I want to express about myself. So it really all comes down to how someone else wants themselves to be seen. Sex is generally, this is the biological indicators. So it's called biological sex. It's in the context of reproduction. These are the internal and external sex organs that you were born with, sex chromosomes, non-ambiguous genitalia, and recognizing that there is some space for there to be ambiguity on external sex genitalia. But generally here in the medical community, we think of gender and sex as the same thing. They were born a female, they are a female. They have XX chromosomes. So this is kind of when you talk in the medical chart about what folks' sex is, or biological sex. That's kind of what we're talking about. I added some slides with these, so I'll try to get to the actual interesting stuff. And so, of course, we do know that there are some differences. There's some sexes that are biological sex that do exist outside of the male-female binary that we've talked about and we've all grown up with. So these are some examples of that really exist outside of that binary. Gender assigned at birth also has to do with your sex, and that is your initial gender assignment is when you pop out, and typically providers will or parents will look at the external genitalia and say, this is a girl, this is a boy, congratulations. And if there's intersex, sometimes it can be a little bit different, and as far as maybe there would be parental preference involved in saying like, well, we're going to raise them as a boy, we're going to raise them as a girl. So there's still some gray area there, even with gender assigned at birth, but generally this is what most of us consider as our gender. So that is a broad overview of this one word gender. So it wraps into identity, expression, and sex, both as assigned at birth and as biological sex. Just wanted to pause and see if there's any questions about that. I feel like I kind of talked through it fairly quickly, but there's going to be more time for questions later. All right. So then what is orientation? This is something that, this is what you're attracted to. So if gender is what we feel about ourselves and what we think of ourselves and what we know about ourselves and what we're told about ourselves, attraction is how we use that self to relate to other people. Attraction and orientation, this has to do, it's not so much inward, but looking outward at who you like, who you want to have relationships with. Orientation refers to a person's sexual or romantic attractions. There are folks who are not interested in sex at all, but they still want to have a romantic relationship with people. You know, you can be romantically attracted or sexually attracted to women or men or combination of both, or neither. So terms about this, orientation, heterosexual is straight. This is the this was the default for a very long time. This is someone who's attracted to a person of the opposite sex. So this is recognizing that there's a binary, that there's male and female, and if you're a male, you're attracted to female. And then homosexual was starting to say like, hey, there's a little bit more to this. People, you know, this is gay, lesbian, queer, someone who's attracted to people of the same sex. Bisexual is typically someone who's attracted to both men and women. And queer can describe any of the above and more. So you get this kind of queer umbrella of not only is it lesbian, gay, bi, intersex, you can have pansexual, which is people who I am attracted to people regardless of how that other person presents. It's all about the actual person, it has nothing to do with their sexual identity. Asexual, again, is someone who I don't like sex at all, but I would love to have a relationship with someone where we go out and go to movies and do have romantic outings that don't involve sex and don't involve kind of the ultimate goal being sex. So I do encourage people to practice. You can know your own identity, and I hope you do know your own identity, have an awareness of your identity expression. You probably know your gender assigned at birth. And if you don't know your gender assigned at birth, it's probably whichever gender you consider yourself. There's also your genetic sex, which most people, it's matches gender assigned at birth. And then sometimes it can surprise you later on. You might not even know until you're trying to have kids of your own that maybe there's something different. And then your orientation, this is who you're attracted to. So each of us, this is not something that is particular to folks of the LGBTQ community, because we all each have our own. There is a range that was considered normal for a long time, and I like to try to avoid using the word normal because really we're all just kind of in different places on our spectrums, and that's and just recognizing that we are on our own spectrum. There's generally a lot of people on various, like on one or the other end of spectrums, but this is something that you can consider about yourself as well. So that is my kind of overview on gender and orientation and identity. Getting into some of our diagnoses. So gender nonconformity is a term that we use as a description, the amount to which a person's identity or role or expression differs from cultural norms, which are attributed to their gender. Examples of this include genderqueer, transgender, gender fluid, non-binary, agender, some of the descriptions we talked about earlier. Gender dysphoria, however, is a diagnosis. It is in the DSM. There's a good chunk of DSM related to it. This refers to the discomfort or distress caused by a discrepancy between someone's identity, someone's gender identity, what they feel about themselves, and their sex assigned at birth. So what other people have looked at their body and told them about themselves. And in the DSM-5, it is distinguished between child and adult. Importantly for this talk too, gender dysphoria is a billable code. This is a billable diagnosis, for better or worse. This is how folks who have any kind of gender nonconformity, if they're going to seek any medical care for it, typically falls under the gender dysphoria diagnosis. Gender dysphoria does have a bit of a patchy history. It used to be, wasn't even in the first DSM. And then the second, the category of sexual deviations was introduced. And that really, and at that time it was called transvestism, later called transsexualism or gender identity disorder. So one thing you can see that these ideas have persisted actually for quite a long time, and it has been sort of different cultural attributions which have led to our understanding of them as disorders or not. And DSM, since DSM-3, there's been a gender identity disorder of childhood. And then growing out of that, there was gender identity disorder for a very long time until we got to gender dysphoria in adolescents or adults. And all of this, a lot of this has been in response to folks who are in the community saying, I don't have a disorder with my identity. I know what my identity is, but it's different from what everyone else is telling me. And then getting into gender dysphoria. So what are the criteria for children? Since we are kind of talking about transition age youth, this is incongruence, so a difference between experienced or expressed gender. So that can be their expression in that, oh, I want to do boy things and I only want to play with boy games when someone has been assigned as a girl. So it's an incongruence between expressed gender and assigned gender. This is for at least 6 months duration, and it's manifested by at least 6 of the following, good old DSM. So you're looking for a strong, number 1 has to be present for the diagnosis, a strong desire to be of the other gender, or an insistence that one is the other gender. So you'll see this sometimes in kiddos when you're saying, you're a boy, and they say, no, I'm a girl. And they're very insistent about that. It's not part of play for them. And you can really kind of tell the difference. And then there's a strong preference for dressing in different, an attire of the opposite gender. This is again going back to that expressed gender. I'm trying to express myself as a different gender. Preference for cross-gender roles and make-believe. So you'll often see kiddos saying like, well, I'll be the wife and I'll stay at home. And if they're taking on gender roles, they will be taking on the perceived gender role of the opposite gender from what they are, or a different gender. You'll see kids with preferences for toys and games and stereotypical activities that are typically associated with the other gender. They might have a strong preference for playmates of the other gender. And then they'll also have a rejection of typically masculine toys. or a strong rejection of typically feminine toys. They might have a strong dislike of their sexual anatomy. And 7 is an interesting one because oftentimes you'll see kiddos present with something like chronic constipation, chronic pain with urination. So some of these, some medical complications or complaints. And it's not until a long time afterwards that you might recognize that, oh, they don't want to acknowledge or engage with their own sexual anatomy, and maybe there's some disconnect there. So kind of gently exploring that, if it's appropriate, is sometimes a good idea. And then a strong desire for primary or secondary sex characteristics to match one's experienced gender. So I really, really, really want breasts. Can't wait to have, like, until they come in. Let's see. In children, you do specify if it is with a disorder of sex development. You typically see the onset of these behaviors between 2 and 4 years old. So you will see these very young. And then they do tend to persist, especially they'll persist past the sort of imaginative play time of life, and they become persistent behaviors. In adolescents and adults, it is fairly similar. It's an incongruence between experienced and expressed, and the assigned gender for at least 6 months. You only need 2 of the following, and there's not one that's you need to have more than the others, but you need an incongruence, again, between expressed and primary or secondary sex characteristics. And here we start seeing things like you want to be rid of someone's primary or secondary sex characteristics because of this incongruence. I don't want to have breasts. I'm trying to minimize them as much as possible. I don't want that to like be expressed and to convey what my gender is. You have a strong desire for the sex characteristics of another gender, or just a strong desire to be of the other gender and seen as a different gender or an alternative gender. Strong desire to be treated as the other or alternative gender. And you also have this strong conviction that someone has the typical feelings and reactions of a different gender. So no, I feel like a woman, I react to these situations like a woman. Specifiers, again, with the disorder of sex development. This is one where you can add a post-transition specifier if they are living full-time as the gender. You do not necessarily, they don't have to have legalization of any of this change in order to be post-transition. This is more of a specifier to you, the clinician, and to other folks that, that this person maybe is transgender or does have gender dysphoria, but sort of trying to get rid of the dysphoria part of it. This person is comfortable living in their cross-sex state. They're living as their desired gender. Maybe they're passing, they're being seen as their desired gender. So there's less dysphoria and more just medical maintenance. Typically does increase in adolescents as they, this dysphoria does, as they approach and anticipate puberty. This is, I like to add this because this just shows how much research is lacking and understanding is lacking about some of these things. The rate of persistence, as is published, ranges from 2.2% to 30% in natal males and 12% to 50% in natal females. So we really have no idea at this point, is what this says. Maybe most, it probably persists, based on people who, based on lived experience, folks generally tend to persist, but scientifically we're far behind in really what we understand. You can also not even specify, but mention in your documentation if it's early onset, which it starts in childhood and persists through adolescence. There is known to be a late onset, which occurs either around puberty or later in life. So someone not recognizing these feelings when they were in childhood does not necessarily disqualify them from having gender dysphoria at puberty or even later in life. Quick differential diagnosis. Good to know if this is just non-conformity to gender roles, young girls being tomboys. This was DSM language was girly boys, and I was tired enough that I could not think of a better term. I don't particularly like that term, but young boys who like to be more feminine, and maybe they like the color pink, but not because they're a girl. They just are a boy who likes the color pink. And then cross-dressing, sometimes that's just for fun, and it's just non-conformity to gender roles because I can wear skirts if I want to. Yeah, I believe Eddie Izzard is a really popular. He's a comedian who is a cross-dressing male. He's like, I'm a man and I like wearing dresses. They're not women's dresses because they're mine, so they're a man's dress. Transvestic disorder is another DSM-5 disorder, and this is folks who, and they're typically male, who are heterosexual or bisexual adults and adolescents, and cross-dressing for them generates sexual excitement. Specifically different from gender dysphoria, because folks who have gender dysphoria, this is not due to generate sexual excitement. And in transvestic disorder, it doesn't, them changing to a different gender, dressing up like a different gender does not cause distress or impairment when they go back to their natal gender. Body dysmorphic disorder, this certainly can occur concordantly with gender dysphoria, but this is when someone focuses on the alteration or removal of specific body parts due to perceived abnormality. This, again, really has nothing to do with gender, but sometimes if someone is very focused on, for example, their external genital, how they look, how it looks, and how maybe if they're doing a lot of, feeling like they can never just look right, it's kind of on that differential. And then schizophrenia has to be considered with gender dysphoria and another psychotic disorder. The biggest difference here is when you treat schizophrenia, you treat psychotic disorders. Typically other delusional content goes away. If you treat gender dysphoria with antipsychotics, it does not go away. It persists. And if you treat someone who has gender dysphoria, who identifies as transgender, and you treat them for schizophrenia if they have it, their schizophrenia typically is able to be better controlled. They have less psychotic symptoms, and they are still transgender. So that is kind of an important distinction as well. Disorders, and I'm going to quickly go through disorders of sexual development. It's not a psychiatric disorder. This is kind of like what we were talking about earlier, a broad range of congenital conditions associated with the development of genital structures. This is more on the medical side. It can include people who identify as intersex, but not all people who have gender dysphoria have a disorder of sexual development. This can also include things like the inappropriate androgen synthesis or action, sex chromosome variations like Turner syndrome, chimerism. These things can be present, and they typically do fall under the umbrella as well of having, they end up having some identity, questions about their own identity, especially once they realize that things maybe are not as straightforward as they thought they were. For gender dysphoria, there's significant barriers to determining the prevalence. But at the current estimation, it's 0.6% of the US population 18 years and older identify as transgender. So at the most conservative estimate, that's 1.4 million individuals. But really you will or likely already have treated a transgender or gender non-conforming patient. They're part of our community, and they are typically much more prevalent, I think, than a lot of people even realize. There is this idea of diversity versus pathology, and this gets into using gender dysphoria as a diagnosis in order to access care for something like trying to live in the gender that you identify with. So there is a World Professional Association of Transgender Health who urge sort of this undoing the pathology associated with gender nonconformity. Not even gonna say that word, but and their stance is the expression of gender characteristics that are not stereotypically associated with one's assigned birth. This is a diverse human phenomenon. It should not necessarily be judged as pathological or negative. So what that means is, should we even be having to give folks a diagnosis in order to access medical treatment for people to live in the gender that they identify with? And then the easy answer to that is that's how our medical system is set up. So there we are. Comorbidities associated with gender nonconformance, and there's higher instances of depression, suicidal ideation, anxiety, substance use, eating disorders, and especially dissociative disorders. The highest vulnerability is in adolescent years. At this point, I do try to normalize with all of my adolescent patients, just asking about their gender, and whether they are presenting cisgender, which is the gender that they express is the same as what they were, assigned at birth, or if they're trans, just asking any of those folks in adolescent years, opening that conversation about gender, especially if I'm seeing them on a psychiatric side. It is significantly reduced by gender affirming care. Some of the best antidepressants you can get if you're a trans person who is depressed is gender affirming hormones. And that has, nothing to do with SSRI. It just has to do with like recognizing that you're able to have power in your own life and let people see you as you want to be seen. So getting into best practices, the primary one is called gender affirming therapy, but this is a therapeutic stance, focuses on affirming a person's gender, not trying to repair it. We will not trying to fix things, but rather trying to affirm. This is a trauma-informed stance, which recognizes that people have experienced transphobia, such as messages and behaviors that discourage gender diversity. They're often repetitive messages, and they can result in physical and psychological effects. Recognizing that these folks have a high experience of shame and depression, feeling flawed or different, and often experiencing repeated trauma. Recognizing that folks in this community have very high levels of suicidal ideation, and they're the victims of violence at a disproportionate rate. What we can do is offer things like medical treatment, and rather than having a place where they are also stigmatized, trying to, you don't have to pass here, you don't have to you don't have to do anything special in order to be treated with respect while you're here. Best practices, definitely please use preferred pronouns. This is something that is certainly noticed by everyone to whom it matters. And these pronouns can be she, her, he, him, they, them. It can be a non-binary z, zim. And it is appropriate to ask if you're uncertain. Offer your own as well. I often, and I usually just go by what it feels like, you know, if someone is gonna respond to that or not. If you make a mistake, it's not a big deal. Just apologize and thank the person for the correction, continue on and try to use the preferred gender or the preferred pronouns. For record keeping, I do recommend, if you have your own practice, making a designated place in your notes or your template to document current gender identity, to document assigned sex at birth, then that sex or biologic or administrative gender, and then also noting preferred pronouns and preferred names. I do recommend having staff training, and this includes front staff, techs, providers, sort of everyone in the practice should be comfortable providing gender affirming care. Visual cues, language on forms or signs, like I've kind of included examples here, that you don't even have to say anything. The cues speak for themselves, and it helps establish when someone walks into a clinic, when they walk into a room thinking, oh, okay, there's people here who probably understand. In outpatient, attempting to make some supportive group therapies available that is gender specific, and then or you know, gender non-conforming. For inpatient, definitely recommended that that transgender, gender non-conforming patients are in gender appropriate rooms, which are associated with their preferred gender. So if someone is male, if they identify as male, they should go in a male room. Single occupancy rooms if available, but that's such a rare occurrence. Please do not stop gender affirming hormones on admission. If need be, consult colleagues who might understand a little bit better, but stopping that gender affirming hormones can be pretty painful for some folks. If you're in the emergency department, simply focusing on the issue that brought the patient in, it might not have anything to do with their gender. But then kind of, if you're belaboring the point of like, no, but what are you? Just feels more and more hostile. Writing letters of support. This is a place where psychiatric providers can certainly come in helpful. Common reasons are for surgery or for gender marker changes on official documentation and paperwork. You do want to consider the patient's capacity. Do they understand what the ongoing implications of making these changes are going to be? So do that to the extent that you feel comfortable, but recognizing that as providers, we are huge gatekeepers, and we can use that sometimes as a way of helping people. Like, you know, I recognize you as male. You're living as a male. I've known you as a male for X amount of years, and then offering to write that letter of support. And so there's a example of a letter of support there. This comes to our learning objectives. We were able to define and describe gender identity, gender assigned at birth, sex and sexual orientation, and gender expression. We specified DSM criteria for gender dysphoria and disorders of sexual development, and briefly looked at the challenges and controversies associated with those. And then hopefully you got a good idea of some best practices for engagement and treatment of transgender and gender non-conforming patients. I did not go into things like specifics like hormone treatment because I'm not an endocrinologist, but it's fairly straightforward. If that's something that anyone has questions about, I'm happy to be a resource regarding that. So what questions do you have? I especially love them when it starts with, this might be a dumb question, but those are the ones that I want.
There's some in the chat. I can do that.
I can't hear you, Nick.
Oh, am I muted? I shouldn't be. Pam,
No.
do you hear me? Huh.
I can
You're
hear you,
just
Nick.
a bit quiet, Nick. And I can
Okay.
hear you.
Okay, I'll try to be louder. Anyway, there's some
I
in the
think
chat.
maybe Molly needs to turn up her
Couldn't hear
volume.
you. I couldn't hear you because my own speaker was turned off.
That's what I was thinking.
I realized when I couldn't hear other people, I was like, oh no, I'm the problem.
I'm
It's
just going to say
me.
there's some in the chat while people are trying to formulate questions out in the real,
Great.
live world. But first, I'm going to do one out of order because this always comes up. Somebody asked if they could get a copy of these slides. And I know that Angela, I think, has these
Yes,
for CMEs.
Yes, you can. I'm actually about to put the link in there where you can get the PDF of all of the presentation slides that we have. So give me a second to get that together.
Okay, and then we'll go back to in order. There's two questions from the chat. One is, how is the word trans used in the LGBT community, and is the word transvestite still used?
So this is a great question. Trans, just that word, just the prefix is often used to identify someone who is transgender. They say, I am trans, or they might say, I am transgender. They might say, I am a trans man, I'm a trans woman, or I'm a transgender man, transgender woman. The term transvestite is still used, but typically by folks who are older in the community. So this is kind of that's a word that was used pretty bad at when time happened, but it was used back when there were no other words.
Okay.
And so now there's kind of some better terms,
Okay.
but I don't think, it depends on the person as far as if it's if it's derogatory, but I would use the word trans or transgender.
The next one in the chat, and I see at least one virtual hand up, but before we get there in the chat is, do you know how common late onset gender dysphoria is for older adults? Is it likely underdiagnosed? I imagine that adult psychiatrists are not commonly discussing this in outpatient clinics.
Definitely, probably underdiagnosed, I would imagine. And I don't know how common it is. And I don't think it is known how common it is.
And then,
yeah.
I'm sorry.
Is that?
I see a virtual hand up for those who know how to do the virtual little hand from Sam Ringer.
Yes.
Oh, that might be me.
Yes, yeah.
Okay, I'm not Sam Ringer, I'm March Kelly, sorry.
Mark.
It's.
Oh,
I think
your name is different than, you must have logged in on somebody else's thing.
I did. I'm
Okay.
sorry. I got a little confused when you were talking about schizophrenia, and there was something you said, and I tried to raise my hand, and then you moved on, and
Sorry.
I forgot quite the question, but there was something about if you give a I don't know. Can you just say a little bit about that?
So this comes out of my personal question too about if what differentiates someone from having schizophrenia or psychosis versus identifying as a different gender.
Okay.
And the biggest difference, well, there's a lot of differences, but the one for clinicians is that if you treat someone with delusional disorder or with schizophrenia, if you treat them with an antipsychotic, most other delusions, with the exception of persistent delusional disorder, but most other delusions will start to resolve, and most other symptoms of psychosis will start to resolve with treatment. The inherent feeling of being a different gender does not actually respond to antipsychotic treatment.
Okay, thank you.
Yeah, definitely.
Okay. I had a quick question myself, actually, which is, so often there's certain words or terms that were okay at one time and they no longer are. And the word queer is one, if you're my age, in the 70s, 80s was not a good thing to say. And now people self-identify as that. And so it's an uncomfortable word for me at 55 to use, but I was wondering if you could just talk about that a little bit.
And I think that came out of there was a big movement to reclaim that word.
Mhm.
And so you do see some of these words that were used previously as a way of keeping someone in check or as a derogatory word, trying to get those as reclaimed. The best thing I could recommend in those situations too, if you're not sure, is to try to use whichever language the person in front of you is using. And if they say, this is what I am, then just use just that term. I identify as a unicorn. Okay, well, what does it feel like as a unicorn? Tell me more about that. Like, how can I make you feel more like a unicorn? How can I assist you in that? And that's sort of like, I'm not saying that to make it sound outrageous, but just that is, especially with kiddos, yeah, let's go down that road. Let's take it seriously and let's see what that means to you.
Okay, there's another one in the chat, but before I do that, for the sake of those who are less technically inclined or good typists, is there anybody out there who wants to just jump in verbally at this point?
I just wanted to jump in on that one. So for example, my adopted moms who are part of the LGBT community do not want to use queer and do not want to be identified as queer, and they do find the word queer very offensive. And so I think I think you're right. For some people, it is still very offensive who are part of the LGBT community.
Thank you.
Yeah, thank you. And transvestite is another word that I've recognized that for young people, it's more offensive, but for older people, they'll say like, no, that's what I am. And so that is kind of another word that really depends on maybe
is there anybody else out there in IRL, as we say, in real life, before I read what's in the chat? Okay, well, real quick in the chat, it says, I would be interested in knowing how many adolescents are exploring these issues just because there is so much of this being discussed on social media and in school environments and in grade school as well.
Yep, I'm so curious to see how that kind of pans out and how it settles, because I do recognize now there is so much more, it's much more available, it's much more out, which I see as a great thing. And it is on social media. And I think it has to do with those questions about really learning how to ask about who am I, what am I, how do I want to live in the world? And those are all questions that we all talked about and we all questioned in our own life, but maybe not necessarily around gender. And now they're asking those around gender as well, which I think is great. And I think they can be supported in that. So I think with adolescents, being more curious and taking a curious stance rather than a no, you're a boy stance, it can be very helpful because they might end up, just being a boy, but they might be a boy who likes skirts. It's all getting much more accepted, which I think is kind of cool. But I also think along the way, there's going to be some people who are like, actually, I thought that was the case about myself and it's not.
And Angela, also, if you're there, or Alexander, just before I wrap this up and see if there's more questions, I didn't know if there's anything as far as CMEs. I remembered last year after each talk, you put the eval in the chat, and I just wanted to give you a chance to jump in if that's the case this time.
Yep, exactly right. I just shared the
okay.
the CE survey link in the chat.
Literally,
so
yes.
You can save that or fill it out now. Just know that each presentation has its own unique survey. So there'll be 3 separate links today. And
the QR code I was sent.
And that is the QR code for today's, for Molly's presentation.
Great. So you could either, I guess, use the QR code if you're so inclined, or if you want, you can just go to the chat and just hit that link, correct?
Exactly right. Yep.
Okay. All right. So
but just one thing regarding CMEs, for those requesting CMEs, when you mark that in the survey, we will be emailing certificates to those folks at a later time. Thanks.
What if we didn't do that? What if we didn't mark it, but we wanted?
Well, you will just need to complete the survey, and then when you
Okay.
complete the survey, you'll choose which CE you're interested in.
Okay.
Perfect.
All righty. And if you have any questions, you can use the chat and you can see who it is there, Alexander. And you can, for those of you, I'm sure everybody knows Zoom nowadays, but you can go ahead and pick exactly who you want to communicate with instead of everybody if you'd like. Well, thank you, Dr. Whitt. That was really interesting. I appreciate that. Yeah. And our second person, let me double check that that's the order we're doing. Yes.
Also, just to let people know, feel free to reach out if there's a question that comes up later, or if there's one that you weren't able to formulate, please reach out. Happy to answer those later.
Oh, great. So I guess, let's see, I'm got 5 things open. So Dr. Whitt, if you are sharing, stop. If you aren't, thank you. And I'll give a chance for Dr. Aurora to start sharing her screen while I introduce her. She is a resident physician training at the Department of Psychiatry at UNM. Her training embraces an integrative approach for advancement of clinical skills through engagement with individuals belonging to various demographics and socioeconomic statuses. Further educational endeavors comprise of neurobiological, psychological, and sociocultural aspects of psychiatry. And with that, I yield the virtual floor, as it were.
I was talking with the mute.
I was about to say, if you're talking, I can't hear you. I was going to give it a second.
Hi, everyone. I'm Molly Wit. I'm one of the psychiatry residents, and it's an honor to be here today and be able to present to you all. Thank you for being here. If anyone has any questions, either during my presentation or after, please feel free to jump in at any point. These are our sponsors, as mentioned earlier. Thank you very much for our Psychiatric Medical Association of New Mexico, and thank you, Nick, for organizing this. And of course, our UNM faculty, Angela, Alex, also helping out with everything today. I appreciate you guys. And of course,
Especially
New Mexico Behavioral Health Collaborative and Human Services Department. This is for anyone who will be receiving the continuing education credits today. I'm sure that there will be a link later on that we can share for everyone to use. And I do not have any financial arrangement related to the content of this presentation. And my views also are not representative of University of New Mexico. They are my own, and if anyone has concerns, please raise them. Before moving forward, I know that the first screen mentioned that my talk will be on psychosis, an overview, and specifically focusing on the transitional age. I think there's some feedback coming. All right, for someone who just joined, but I think that's resolved. So I'll be talking about different clinical symptoms of psychosis, how there's different types of illnesses that are part of a psychiatric diagnosis for psychosis, and further look into the medical related causes of psychosis related to substance use, and in addition to some medications, but specifically focusing on how psychosis and illnesses such as schizophrenia are impacting our youth in the community and what sort of demographics exist. The transitional age youth comprises of individuals who are 16 to 24 years old. At that time, and they are coming into a new phase of life. They're experiencing new challenges. They're having new experiences, they're having to deal with new environments and tackle them, but likely in the absence of having proper guidance for day-to-day activities such as dealing with paying rent or getting groceries from the stores, especially because often the youth are either away from home and parents and have limited resources such as finances, or may even lack social or familial support, which is a foundation for further emotional distress. The demands of independent living and adjusting to many new phases in life, for example, like I mentioned earlier, managing own expenses, adapting to study, or even determining how to adjust to a new phase of life, that can be very detrimental for some folks, especially those who are having a baseline and underlying mental illness. A lot of these experiences are also precipitating factors to develop mental health distress and problems during the transitional age. A lot of the folks are given responsibility and expected to manage them on their own and cope with their obstacles, but they're not really provided with resources or even a foundation to be able to know how to ask for help. The years from transitioning from adolescence to adulthood have challenges and increase the risk for having mental illness. Additionally, enormous hurdles for youth aging out of foster care or leaving the juvenile system while suffering for behavioral health problems arise, yet not very many of them truly seek mental health help from professionals. In these instances, resilience may be a protective factor for those to be able to adapt and change to the circumstances, to be able to equip them with strategies to face difficulties and recover from the setbacks. However, poor resilience can lead to emotional distress and vulnerability, which is a risk factor for self-harming tendencies. Some individuals turn to maladaptive coping mechanisms, such as drug or alcohol dependence or misuse, to escape their troubles. During these transitional phases, the youth are at risk for developing syndromes such as depression, anxiety, bipolar disorder, schizophrenia, and other mental illnesses. And other psychoses, which I will talk about shortly. Approximately 75% of individuals with serious mental illness, including schizophrenia spectrum disorders, bipolar disorder, major depressive disorder, approximately 75% of these illnesses develop by the age 24. In 2019, prevalence of serious mental illness in USA was highest among young adults age 18 to 25 at approximately 9% compared to close to 7% for ages 25 to 49 and about 3% for 50 years and older. Despite early onset and higher prevalence of mental illness in transitional age youth, only a small fraction of young adults with serious mental illness receive mental health services. Furthermore, both transitional age youth and adults from African American and Latino origins in mental illness are less likely to receive mental health care than their non-Hispanic white counterparts. Before we talk about the epidemiology of certain psychotic disorder, let's first talk about what psychosis is characterized by. When we think about the positive symptoms of psychosis, these of course include hallucinations, which are perceptual changes. And before I forget to mention, positive symptoms of psychosis are things that are there that are typically not there in other individuals. They're added onto a person's experiences and includes changes in thoughts and feelings. So as I was mentioning, hallucinations are perceptual changes, including auditory hallucinations, which is hearing voices that are present in about 2/3 of patients over the course of their illness. Other hallucinations, such as visual hallucinations, are possible, but should also raise concern for some other etiologies such as migraines or seizures, or even looking into some ophthalmology concerns, and should raise probability for a clinician to look into other causes of possible psychosis development. And we will talk more about that in a little while. Now, delusions are fixed false beliefs, non-culturally sanctioned beliefs that are held with great conviction, even in the face of overwhelming evidence to the contrary. Schizophrenia usually has bizarre delusions, which is includes of content that is impossible based on day-to-day our laws of physics, for example. There's different types of delusions that we will talk about shortly that may also exist as part of psychotic disorders. Disorganization is disruption in daily changes and activities, behavior, speech, and emotion. As I mentioned earlier, delusions are strongly held beliefs that are inconsistent with a person's reality. A lot of these may include erotomanic delusions, which is when a person believes that another person of higher power perhaps is in love with them. Grandiosity is a delusion where a person may have thoughts that they have an inflated self-worth and knowledge and are maybe related to a prominent person in society. Jealousy delusions can develop in individuals believing that a lover is unfaithful. One of the most common delusions as part of schizophrenia and other psychotic illnesses is persecutory delusions, just believing that other people are malevolently after you, and they induce paranoid thoughts in these folks, making them feel that they're getting conspired against or cheated on or poisoned or spied upon. Some individuals may also have somatic delusions, which means that they have a physical defect or general medical condition, and they truly believe that that ailment exists. Some people may have a mixed number of themes together, or some of them may not fit the themes that we just spoke about. I do want to recognize that delusions can be part of an underlying psychotic illness, like schizophrenia, or on its own be a disorder called delusional disorder, which typically is not as interfering as psychotic illnesses in one's life. And there's typically no hallucinations or disorganization in addition to delusions for those folks. Now, thinking about the negative symptoms of psychosis, negative symptoms are things that are taken away or reduced from a person. Some of the most common ones in folks with psychotic illnesses include blunted affect, which is diminished expression of emotion, both facial and verbal. Avolition is one where they have lack of or reduced motivation, perhaps, to engage in daily activities such as self-care, doing work and school work activities. They may get fired from their jobs or fail classes that they previously were thriving in. Their relationships may get impacted. Alogia is another symptom of psychosis that is characterized under the negative symptoms, just reduced quality and quantity of spoken words. Some people may even avoid conversation because of what they're experiencing inside. Asociality is another symptom, which is social withdrawal, may not have that many friends, or may have had friends that they're no longer engaging with. They're not interested in relationships with even family. Anhedonia is another one of the negative symptoms that's commonly present in folks, which is reduction in enjoyable experiences that were previously not impacted. They no longer enjoy things they used to like to do. Negative symptoms can be present with positive symptoms in 20% of people with schizophrenia. Up to 60% of patients may have prominent clinically relevant negative symptoms that actually truly require treatment. Do want to recognize that negative symptoms can be present at any point of the illness throughout its course of lifetime, but they are typically one of the symptoms that are reported to be first signs that emerge as part of a psychotic illness. Most negative symptoms, like I mentioned earlier, included social withdrawal, blunted affect, and avolition, in addition to poor report. In first episode psychosis, negative symptoms are present in about 90% of individuals, and 35 to 70% of individuals continue to have persistent negative symptoms throughout the course of their illness, despite actually receiving treatment. In addition, there's cognitive deficits that are part of the illness, which may not improve over the course of overall impairment, and despite getting treatment, those symptoms are really difficult to treat. Now, thinking about the etiology of psychosis, there's evidence from neurochemistry, from cellular pathology and neuroimaging studies that support that schizophrenia is indeed disease manifested by brain structure abnormalities, function, or perhaps a mixture of both. And there's not a single universally accepted theory regarding the brain dysfunction in schizophrenia, but rather that there are a host of competing and overlapping models. Dopamine is a neurotransmitter that is involved in brain function, including movement, thoughts, emotions, motivation, interest, reward, and activities, such as daily acts of walking and talking. Impairment of such brain functions are suspected to underlie symptoms of psychosis. And this is the dopamine hypothesis of schizophrenia, that elevated dopamine synthesis in people who are at risk for schizophrenia may be predictive of later development of psychosis. This is supported by neuroimaging evidence that has demonstrated that there's more dopamine being produced in certain parts of the brain and not enough in other parts of the brain. Additionally, MRI scans of folks have shown that patients with schizophrenia have larger ventricle volumes, which is the space where the cerebrospinal fluid lives, and reductions in the actual brain volume. They have lower amounts of brain tissue regionally. In addition, the rate of volume change, which is the brain tissue loss over time that happens in a person's life and with aging. But however, in patients with schizophrenia, this rate of volume change is more than twice than that of other healthy subjects. As I was mentioning, that there's not one universally accepted theory, and that there's likely a number of things that may be going on that are causing psychosis. In addition to dopamine, glutamate is another neurotransmitter thought to be involved in development of psychosis. Glutamate is an excitatory brain molecule which regulates daily the neuronal cell signaling, memory, and learning. And in addition to dopamine, low function in glutamate system is thought to be involved in development of schizophrenia and other psychotic illnesses. Yet both dopamine and glutamate play distinct roles in regular neural functioning and nerve signaling. Now, in overall effect, we have to recognize that there's two parts to the dopamine involvement. Like I mentioned earlier, there's too much dopamine in one part of the brain that's causing the positive symptoms. And there's not enough dopamine in one part of the brain, which is responsible for the negative and cognitive symptoms, for things that aren't there and should usually be there. Thinking about, psychosis versus schizophrenia, I want to help recognize that psychosis can just be an episode where a person is detached from reality. and they may not feel like they're part of their environment. But this can be secondary to sleep deprivation, maybe because someone is using substances such as methamphetamine, or they may have an underlying mental illness or a medical condition. But schizophrenia overall is a chronic mental illness. It's not just one episode. It impacts a person's thoughts, behaviors, emotions, and truly is functional impairment in folks who have the disturbance. Cultural beliefs, prejudice, and stigma, however, view a person with schizophrenia or other psychotic disorders as an odd entity in society, which affects their clinical realm of receiving the treatment, because folks then may not want to get treatment because of the prejudice against the illness they're experiencing. Psychotic syndromes such as schizophrenia are far more common than we realize. Schizophrenia has an incidence of about 7 to 43 new cases per 100,000 folks annually worldwide, and a lifetime prevalence of about 0.3 to 0.7%. Though, of course, there's variation by race, ethnicity, cultural background, and the geographic origins. The psychotic features typically manifest gradually in majority of the folks. And like I mentioned earlier, half of these may initially be observed as negative symptoms. And a lot of folks complain of depressive symptoms when they start developing this syndrome. The emergence of such symptoms is typically around late adolescence to early adulthood and mid-30s. However, most patients present between ages 15 to 45. The peak age of onset for first psychotic episode is early to mid-20s for males and typically late 20s in females. However, they are late onset cases between ages 55 and 64 years of age in women who present with predominantly psychotic features, but typically their affect is preserved and not quite impaired compared to folks who present at an earlier time, such as for males. In addition, a lot of females may have an intactment in their social functioning. It may not be as impaired as it would for someone who presented at an earlier age. The debilitating illness also has a mortality rate of 2.5-fold the general population. And the life expectancy reduces by 15 years, mostly from suicide, but also attributable to premature cardiovascular heart complications. Now, there are quite a few risk factors that have been associated with higher risk of development of schizophrenia. It is hypothesized that gene and environment interactions are responsible for the development of the syndrome. It is suspected that clinically silent propensity towards schizophrenia, such as genetic vulnerability, gets uncovered due to insults during brain maturation and development, such as infections in the mother while she's pregnant. Additionally, cannabis use affects brain maturation during a person's lifetime and pushes a vulnerable brain towards psychosis. For someone who may have a genetic propensity, it then gets pushed into active psychosis with use of cannabis. There's been evidence that there are environmental factors such as season of birth, late winter, early spring, or location like urban environments may be related to development of schizophrenia. In addition, highest risk exists among children of first-generation immigrants, followed by immigrants themselves, because it's a huge life-changing event that may be traumatic for some folks. An individual who has a first-degree relative, such as your siblings or your parents, has a 10-fold increased risk of developing schizophrenia, whereas it's about 2-fold increase for someone who's a second-degree relative. In twin studies, for twins that are from the same cell, the monozygotic twins, the risk approaches for 50% for the unaffected twin. For Maternal age also increases the risk by twofold for fathers who are aged 45 to 49. Genetic syndromes such as DiGeorge syndrome or Klinefelter syndrome, where they may have an additional X as part of their chromosomes, is also related to development of schizophrenia. Physiological changes such as pregnancy and obstetric complications are also related to development of schizophrenia, especially influenza exposure during first half of the pregnancy, in addition to rubella, toxoplasma gondii, which is another infection. Stress is another one that can impact the development of the fetus's brain. Nutritional deficiencies such as maternal folate levels and too much of homocysteine can cause that. There's been concerns that maternal malnutrition, especially starvation during the first trimester, may be contributing to development of long-term issues. In addition, there's possible that RH compatibility, hypoxia, which is low oxygen levels, preeclampsia, which is a complication of during pregnancy, maternal diabetes, etc., can be related to development of schizophrenia in the fetus as well. But it's important to note that most of the offspring of these individuals who may have had pregnancy or obstetric complications do not actually develop schizophrenia, but that there's an increased risk for those who may have those situations. Now, in addition to schizophrenia, which we spoke about, there's other psychiatric illnesses that can contribute to psychotic illness. Specifically, there's schizoaffective disorder, where a person doesn't just have psychotic symptoms, they also have mood symptoms. A brief psychotic disorder, where someone may have just symptoms present for 1 month and they resolve. And these include only the positive symptoms, not negative symptoms of psychosis. Delusional disorder is one that we spoke about earlier. There's major depressive disorder, so a person who may be suffering from depression but has additional features of psychosis as part of their illness. There can also be bipolar disorder with psychotic features, so someone who has manic episodes may or may not present with psychotic features as well. And one thing to remember is major neurocognitive disorder for our elderly individuals who have behavioral disturbances. They often have paranoia that someone in the family is after them or trying to get their resources or just exploiting them financially, which may very well be happening. But remember that can also be part of someone's mental cognition at the time of their illness. There's, like I mentioned earlier, genetic predisposition to schizophrenia and other psychotic illnesses, including biological changes in the transmitter circuitry. Social factors such as cultural, familial, socioeconomic, medical, financial distress, previous trauma, sexual abuse, or even sexual orientation can be huge factors that may be contributing to the vulnerability that we spoke about earlier, and how that can cause a brain to have distress and further have the propensity to develop psychosis. Now, let's not forget about the medical causes of psychosis. There is quite a few number of conditions that can be contributing to a person's psychotic presentation, such as thyroid issues. Person's hypo or hyperthyroidism can present with psychotic features. Someone may have an infection of the brain, whether that's during the actual development for the fetus versus later on in life, that they can present with themselves that may be contributing to psychosis. A lot of neurological conditions such as Parkinson's disease, Huntington's disease, there's dementia, as we mentioned, brain tumors can cause psychotic symptoms. There's poisoning such as lead or carbon monoxide, or heavy metal consumption such as copper, calcium, iron, or manganese, nutritional deficiencies, different types of brain vasculature changes such as subdural hematoma or Wernicke's aphasia can also be contributing factors. But also remembering that certain medications can cause psychotic symptoms to develop. These include HIV treatment medications, some antibiotics, some anticholinergics, some steroids can cause that, and some blood pressure medications can also cause that. Life expectancy is reduced in individuals with schizophrenia because of the associated medical conditions that are resultant of some of the treatments that are used for this schizophrenia in general and all the psychotic symptoms. These include metabolic syndrome, which includes weight gain, diabetes, cardiovascular, and pulmonary disease, which is more common in folks with schizophrenia than the general population. And a lot of folks, because of their illness itself and the negative symptoms they may be having, they are unlikely to engage in treatment that's offered to them. So they have poor engagement in the health maintenance, like routine checkups, for example, cancer screenings, or even walking around the block, 20 minutes a day for exercise purposes, which all of these things increase the risk for chronic medical disease in these folks. Psychosis also can be contributed to substance use. It can be when someone is actively intoxicated that they just use, or they may be withdrawing from certain types of substances. A person who may be coming in may be really calm and redirectable if they are intoxicated, for example, with benzodiazepines, or they may be really agitated or violent and aggressive with hallucinations or delusions. Some of the causes of the different types of substances include methamphetamine and cocaine. In addition, there's PCP. So one of the biggest differences to note between cocaine intoxication and PCP intoxication, because they present very similarly with elevated heart rate, blood pressure changes, and sweating. PCP, in addition, has typically visual hallucinations in addition to the other physiological changes. I now mention some of the substances such as the stimulants or benzodiazepine or hallucinogens that can cause psychosis, but even caffeine can have some sort of a involvement in development of psychosis if taken in high doses. So the total daily dose recommendation for coffee is 200 milligrams. A Folgers cup of coffee has about 80 milligrams. A Starbucks drink typically has around 200. So I don't know, maybe somehow at some point, if people are over caffeinated, they may even experience psychosis. So that can be part of their presenting illness. It's important to then consider in knowing that there's a lot of medical causes that can be related to development of psychosis. To remind ourselves that there's medical workup for psychosis that also needs to be actively sought after. These includes general labs, like I mentioned earlier. Thyroid changes can cause that, so important to get thyroid labs. The B12, B1 being certain types of vitamins that need to be checked. Folks who may have underlying medical complications due to HIV may also be presenting with psychosis, so it's important to look into their blood levels for their specific cells that are indicative of the counts for how well your body is doing or not doing to the treatment. Often folks, especially elderly folks, who may not be eating adequate amounts of food on a daily basis. They may have changes in their chemistry. So it's important to look into the electrolytes for those folks. And especially for the elderly, in addition to that, it's important to look into a urine sample because they may be having a UTI that's contributing to their psychotic feature that they may be coming into a clinic or a hospital with, in addition to blood infections. Often people with dementia also may not have the idea that they're having some sort of a medical deficit. They're unable to explain those symptoms because they cannot recognize them. So it's important for caretakers to be mindful of those things when evaluating the cause of someone's psychosis. Now there's different types of management strategies that can be used to help someone with psychosis. But initially, and they should always be the first way to handle such folks who may be agitated or aggressive, always using verbal de-escalation, reducing the environment that they're in, making a quiet room with low light. Medications can be used as an assisted treatment, such as to calm those folks, but not really sedate them. And it's important that we offer oral medication before giving someone injections. Listening actively and letting the folks talk, even if they're not making sense because they may be disorganized when they come in. But this is kind of funny to say that do not ask them to stop crying, because people do that. And people that I've seen in our psychiatric emergency services have mentioned that sometimes people are unwilling to hear them out, and that's the biggest distress that they're facing. So some of the medication approaches that can be used to help people who are coming in with a psychotic presentation, typically using a combination of low-dose antipsychotic with a low-dose benzodiazepine for someone who is agitated and aggressive, for someone who may be intoxicated with substances, and whether they're withdrawing from alcohol or benzodiazepine use, or actively intoxicated with methamphetamine or cocaine, it might be useful to just use benzodiazepines for them. For someone who is coming in with delirium, which is a fluctuation in altering of your orientation and awareness of your surroundings, can be related to a medical cause. And in those situations, we should not use benzodiazepines that are going to make their mental status worse. And this is just a summary of certain types of medications that we use when folks come into our psychiatric emergency services. Now, thinking about the course of illness of psychosis and how it actually turns out, it's supposed to be better than we expect, but it's actually suboptimal for a lot of individuals. Most individuals with schizophrenia require formal and informal daily living supports, and many remain in chronically ill with kind of a cycle of exacerbation of symptoms and remission of symptoms, and then it becomes a cycle of constantly coming in, getting admitted, getting discharged, coming in, going on and on. Important to be aware that this is related to a core feature for patients who have schizophrenia and other psychotic disorders, is the lack of insight, which is the inability to recognize symptoms, to consider that the person may be suffering from a disease, or to accept treatment for the illness. It's a common predicting factor for treatment non-adherence, and predicts higher rate of relapse for individuals who then do not take their medications as prescribed. which then leads to increased number of involuntary treatments and hospitalizations. They may have poor psychosocial functioning, like impacting their life in as far as their familial aspects or social aspects. There may be occupational dysfunction. A lot of folks with psychosis present with aggression, and which is more frequent in younger males, especially those who have history of medication non-adherence and those with history of violence or substance use and impulsivity. However, it's important to note that vast majority of folks who have schizophrenia are not aggressive and are frequently the ones who get victimized than ones who victimize other folks in the general population. There's a lot of, like I mentioned earlier, the social and occupational dysfunctional functional consequences that occur as part of a psychotic illness include changes in their employment. They may not be able to maintain one job or make educational progress that they had strived to before. And most individuals are employed at a lower rate than their parents, and particularly men do not marry or may have limited social contacts outside of family. There's an increased risk of suicide in persons with schizophrenia. Approximately 5 to 6% of individuals with schizophrenia die by suicide, and 20% of them, or 20% of folks with schizophrenia attempt suicide one or more times during the course of their lifetime suffering. The individuals often have significant suicidal thoughts related to their hallucinations they may be experiencing. They may also have suicidal thoughts because of not having a social family to relate to, or actually have a sense of belonging in the society that they're living in. Other risk factors for having suicidal thoughts include hopelessness and just depression in general, which is related to not having social or financial stability in their life. It's important to remember that suicidality is one of the highest times of having suicidal ideations is after getting discharged from the hospital or having a psychotic episode. So if it gets treated, great, but it's important to know that it can be a really high risk factor for someone to try to hurt themselves. Suicide risk remains high over the lifetime span for both males and females, but it's especially higher for younger male who are actively using other substances. Even though psychosis is a debilitating syndrome with poor functional outcomes, stigma still exists. According to World Health Organization, about 1 of 4 people who have a mental illness commit suicide. Every 42nd person dies from suicide worldwide. The burden of mental illness is growing and notably impacting our economy and social structures negatively. Moreover, the cost of treatment is considerably high, which further contributes to a person's burden. In developing countries, 70 to 85% of low and middle income citizens do not receive proper treatment. Further, mental health crisis emergence at a vulnerable transitional age may make the youth think that they do not have the skill to navigate their distress, or may lead to hesitance to ask for help because of the expectation from society for young people to deal with their problems on their own and to be responsible for their lives. This way of thinking, intermixed with low mental health literacy, prevents them to access counseling assistance or mental health services because they're afraid to be considered incapable of dealing with their difficulties. Despite the frequency of suicidality, anxiety, and depression in folks who have psychotic illnesses, studies have shown that 60 to 80% of transitional age youth, ages 16 to 24, are not in treatment. An individual's emotional wellness guides the trajectory of their general well-being, including their physical, social, behavioral, and occupational domains. A person's thoughts and emotions affect their physical health, and a physiological impairment on its own can impact one's behavioral preferences. Yet, microaggressions related to mental illness remain prominent in society because of limited awareness. The stigmatizing attitude toward people experiencing mental illness worsen the burden of their distress and pose challenges to receive the necessary treatment and support, especially knowing that people who have mental illnesses need the social and emotional support from their surroundings and closest peers. The misconstrued perspectives interfere with healing, which is vital for youth who are attempting to navigate the norms of personal, social, ethical, and moral development at such a young age. Negative stigma results from a lack of awareness and education about mental health. But I hope for folks who attended this talk today, that I hope that this presentation helped recognize such symptoms and explore the causes of the illness and identify non-psychiatric aspects which may contribute to perceptual changes in a person. Because understanding the challenging symptoms of psychosis is crucial to reduce negative beliefs about the illness and to advocate for folks who need treatment at an earlier and more suitable time. These are my references, and thank you very much for your time.
Thanks, Dr. Aurora. Okay, yeah, there's the evaluation stuff. And again, it'll be in the chat in a second where you can just click on a link if QR codes aren't your thing. And while folks out there are figuring out their questions or how to electronically raise their hands, there is one question in the comments. It says, you mentioned cannabis continues to affect brain maturation. In my studies, I have found it does only to about ages 23 to 25, unless you are referring only to schizophrenia. That was the question from Mark O'Neill. If you need clarification.
Right, and that's especially applicable to transitional age youth, because that's the time that their brain is going through development. A lot of folks think that their brains are matured in early adolescence, and they may not think that the brains continue to develop up until those ages. And it's important to recognize that even if they may not have used cannabis till a later time in their lifetime, maybe after age 25, there's still studies showing evidence that it could be possibly related, specifically high THC content in cannabis, that's related to the psychotic illness development.
I don't see any electronic hands up. Is there anybody out there who has a question and wants to just unmute themselves and jump in? Let's see, message, let me check. Somebody asked, I am sure it is important to rule out any medical contributing factors prior to diagnosis, question mark.
Yes, absolutely. And that's what, for folks to get admitted to our mental health facility, the inpatient hospital, we always do a full medical workup for contributing factors. And especially if someone has a known family history of certain conditions, then we want to evaluate them with, such as imaging. I recently had a colleague who had a patient in the inpatient unit who had a family history of brain vessel structure disease, to say it in the simplest terms. And turns out that that person needed to be evaluated with brain imaging to rule out such a factor that may be contributing to development of psychosis in a male who was 49 years old. So
And,
absolutely agree. Yes. To rule
and I'm
out
not sure if,
these conditions.
yes, and I'm not sure if I mentioned it, I was up a couple of times, but do you see any sort of attempt to self-medicate for people who have schizophrenia?
Absolutely. Yeah. Often people, in order to kind of bring their thoughts together and not be so distracted with the voices, etc., they tend to use different sorts of substances, especially folks using methamphetamine to not be so distracted by everything that's going on in their brain. Or sometimes that's even used to get motivation to do things because they don't have a motivation as part of their negative symptoms of psychosis to be able to be part of society. A lot of folks with schizophrenia and other psychotic illnesses also have low socioeconomic statuses and may be homeless. So I've heard from folks that they may use substances to stay awake on the street, to be aware of their surroundings and not get hurt. But often, you know, people also use alcohol and benzodiazepines illicitly to help themselves.
Okay. Is there anybody else out there before we move on? Yes, okay, one popped up. I had a few. What are your thoughts about synthetic weed, K2, spice, etc., causing psychosis? Many argue it's harmless. However, I have heard other stories.
Yeah, it's definitely not harmless. I would say that. Yeah, it has. I know that even though it doesn't show up on drug screens as positive cannabis or cannabinoids or THC, but it is definitely something to remind patients we see in any clinical setting, to remind them not to use those things, because more and more people are coming into the hospitals when using such substances and having psychotic symptoms that they never had before and have no history of prior use or even family history that may make them have a higher propensity for development of the disease.
Great. We also have our last person's coming up, but I think we're having a little technical issue with them. So it's also a good time for a break since we've had 2 of our 3 folks present. So it's 1:51. So why don't you all come back within 4 to 5 minutes for sure, but be patient if for some reason it takes a few more minutes. That way you're not missing anything, but everybody gets a break for necessities, as it were. All right, everybody, thank you. And you know, you can drop things in the chat too, and if we have time at the very end, we can try to see if we clear up any questions that didn't get answered. All right, thanks everybody. See you in a few minutes.
Thank you.
Oh, I did go ahead and read your bio, so we took care of that. And so now if you're ready, you can get started. Is it okay to start yet?
Yeah, and you guys are seeing just the slide, right? Like not the note.
Correct, yeah, just the slides, not the little thingy on the side.
Perfect. All righty. Okay, well, sorry for the technical delays. That was very strange. But I'm going to be presenting on eating disorders, specifically in Asian American youth, but I tried to expand it to bicultural identities, and because New Mexico is such a diverse state and one of 5 minority states as well in the US. But this was a population of interest of mine, which is why I will be focusing on eating disorders in Asian American youth. And this is very pertinent to transitional age youth because so much of the initial diagnosis with eating disorders presents in adolescents or children or transitional age youth, which we'll get into. So these are my introductory slides. Thank you to New Mexico Psychiatric Medical Association for the CMEs, no disclosures, and the eval code. So the objectives today are to recognize the prevalence of eating disorders in Asian youth, identify risk factors, formulate how culture can affect youth in their experience of eating disorders, interpret how cultural factors can present challenges and strengths in the treatment of eating disorders through medications, which I'll talk about, and various treatments, including family-based therapy, which is really the gold standard, which we'll talk about, and appreciate the challenges and strengths that Asian cultures or all cultures can add to the treatment of psychiatric disorders. So as I mentioned before, why is it so important to study eating disorders? Eating disorders are contested as one of the most lethal psychiatric disorders in all mental illnesses. Sometimes, depending on how you word lethal or amount of suicide attempts, it can be contested with bipolar because they have a lot of attempts. But for those, if you look within those diagnosed with eating disorders, they may not be as prevalent as some other mental illnesses. It has the highest mortality rate because if you think about it, these folks are so medically frail that, you know, I think a good theory about it, which has been taught to me, is that, you know, when these folks attempt to do anything, or even when they exert themselves a little bit more, say their cardiac risk is already so much higher because they're so weak or they're so medically frail that it takes very little for something unfortunate to happen to them when they do attempt anything. So that is one very important reason to study eating disorders, because it's so easy for any attempt or anything to take them out. Additionally, early intervention has been shown to improve outcomes with individuals with eating disorders. So this is something that we should really stop in its tracks in adolescents or transitional age youth. And as some of you may have heard, studies have shown that disordered eating, whether or not it is a formal eating disorder, especially because there were difficulties with getting access to mental health care during COVID, have increased. And some people say that that could be from people already with eating disorders having a lack of regularity, or those with some disordered eating symptoms, you know, being isolated from peers, not having that accountability of, you know, lunch at school or lunch with coworkers, and skipping meals. Or on the other hand, like those with binge eating disorder, you know, not having the structure and being around food and at home all the time. So just something to keep aware of. So why is it specifically important to study eating disorders in ethnic minorities? The special focus of this talk. Most research historically has focused on eating disorders on white females. But there's been new literature showing increasing rates in ethnic minorities, males, and the transgender populations. It's really hard to study eating disorders and the prevalences of them based on what is formally diagnosed or not diagnosed because of the underutilization of mental health services by non-white groups, which I will cite throughout this talk. But it has been shown with studies, both in the US and outside of the US, that in terms of disordered eating symptoms, not necessarily a formal eating disorder, but say, for example, dissatisfaction with the body, that there's been rates that show that non-white groups typically are even at the same level of white groups or even higher, even though the prevalence of a formal diagnosed eating disorder is lower. That's kind of highlighting what I just mentioned about, you know, even though maybe they may not formally be diagnosed with them, the dissatisfaction might still be there, leading to untreated diagnoses. And furthermore, there was a study by Gordon and colleagues that showed that when clinicians were given identical case vignettes about various groups, white, Hispanic, and Black females, a greater proportion of clinicians diagnosed the whites as having a problematic eating disorder, but fewer for the Black individuals, showing that there may be some problem with the diagnosis because they were identical vignettes and what the clinicians are perceiving themselves, and possibly, you know, preconceived stereotypes of what an eating disorder is supposed to look like. So I wouldn't be doing my job if I didn't go into a broad overview of what is in the DSM-5 on feeding and eating disorders, which largely has been unchanged in the updated version of the TR version. I'm going to cover all of them besides pica and rumination, which are feeding disorders and not as specific for transitional age youth. Those disorders are feeding disorders that are more prevalent to developmental or autism spectrum disorder. So criteria for anorexia per the DSM, I'm just going to highlight some parts of these. I wanted to say that, it mentions that it's restriction of energy intake or food leading to a low body weight in the context of age, sex, developmental trajectory, and physical health. That's really important because a lot of these disorders present in, adolescence or childhood, like I mentioned. And sometimes kids are already small for stature to begin with, but we really want to look at growth curves. And if they drop off, if they were already small and they continue to drop off more, that's concerning. Or if they were bigger and they drop off. For kids, we expect them to be somewhat steady or continuing to grow. So that's something in terms of the developmental trajectory. And also these fears of gaining weight are critical to the diagnosis for anorexia nervosa. I know we are on to the DSM-5 TR, but something that was changed from DSM-4 to DSM-5 is taking out the requirement for amenorrhea or loss of menstrual cycles, because that is something that can present. Everyone's body is different, and some people might still have periods at a very low weight. There can be atypical anorexia, so they took that criteria out. For bulimia nervosa, it is eating in a 2-hour period an amount of food larger than what most would eat under similar circumstances and feeling that one cannot stop eating or control it, and then recurrent inappropriate compensatory behaviors to prevent weight gain, various means, vomiting, laxatives, diuretics, or fasting or excessive exercise. These occur 1 time per week for at least 3 months. So this was changed from the DSM-4 to 5, as at that time it was 2 times a week, and they lowered the threshold for that down to 1 time per week. And once again, as you can see, critical for these disorders is eating disorders is the self-evaluation or the importance placed on the individual on body shape and size. So some warning signs for this, if you're suspecting it in an adolescent or transitional age youth or anyone, is, if they're going to the bathroom after meals immediately a lot, if there's large amounts of food from the home disappearing all of a sudden, that could be a sign of binging, especially if there's not, the weight gain that you would expect from all the food disappearing, having puffy cheeks. Sometimes dentists can be the first ones to figure this out because they notice the enamel of the teeth wearing out, which is another medical complication of it. Or, having scars on the knuckles, like right here, from people self-inducing purging by vomiting. But as pointed out before, this can be something that can be not just self-induced vomiting, but laxatives, diuretics, which can cause a lot of electrolyte imbalances as well. And then this is going to be kind of a catch-all slide for some other eating disorders and feeding disorders. So on our left-hand and middle column, we have 2 eating disorders, and then we have a feeding disorder of Rfid, so I'll get to those. So binge eating disorder is unique because it is like bulimia nervosa to an extent, where you eat until you feel like you can't stop, more than a typical person would do in that time period. It's not like considered a binge if it's Thanksgiving meal. It's more than what someone would do in that circumstance. And similar, you see the time frame again occurs at least 1 time a week for 3 months, but no compensatory behaviors like in bulimia nervosa. And binge eating disorder is unique because it has an almost equal gender distribution between males and females, whereas anorexia and bulimia are still female predominant, even though, as I mentioned before, we're seeing those rising rates of male or transgender youth being diagnosed with them. OSFED, or other specified feeding or eating disorder. This one is kind of the catch-all where if you don't meet a certain criteria for the other diagnoses, for example, if you have features of anorexia nervosa where you're restricting intensely, but you're not at that vague term of a low body weight, you might fit into OSFED. Or maybe if you are binging and purging, but not to the extent of 1 time a week for 3 months, you could be diagnosed with OSFED. So this is kind of the unspecified eating disorder category, which was previously called EDNOS, or eating disorder not otherwise specified in DSM-4. If you still hear that term, it's still kind of used, even though now technically in the DSM-5, an updated version of the DSM-5, it's OSFED. Uniquely, there's also Rfid, Avoidant Restrictive Food Intake Disorder. So this is, oops, sorry about that. I don't know what happened there. 1 second. Okay, you guys should be seeing my slides again. And this is an eating disturbance. It's not necessarily, it's more of a feeding disorder rather than an eating disorder. And it's where adolescents or individuals fail to meet their nutritional needs because of a disturbance or a dislike of certain foods often. So it does cause them to have significant weight loss, nutritional deficiencies. They don't necessarily have to be, you know, rail thin, but it's something where they're causing damage to their health by the nutritional deficiencies. And oftentimes this is seen very commonly in developmental disorders such as intellectual disability or autism disorder or anxiety or OCD. What makes it different than, say, like anorexia, even though sometimes I have seen individuals with Rfid who are very, very low weight, is because it's not weight or body image driven, as I pointed out for anorexia and bulimia. That's why I wanted to highlight that for those disorders. So you might be wondering, so what would be something like Rfid? It would be something like a child who will only eat cold foods because they fear the sensation of hot foods, or they dislike the sensation of hot foods. I've seen cases of Rfid where kids will literally restrict down to, say, like 5 foods, like chicken nuggets, spaghetti, you know, ramen, and that's all they eat. And you can imagine that if they keep doing this for a prolonged time, it does cause significant nutritional deficiencies and cause them to have health problems because of that. And you can see from what I described why it might be so common with other disorders such as autism spectrum disorder, because sometimes kids have fears of these foods, or they really just like sensory issues with certain foods. Say they'll only eat soft foods or something, and it ends up really restricting their diets. So then I also wanted to go into some disorders really quickly that are not formally in the DSM-5, but I thought were important to touch on because they are disorders that maybe you hear in social media or pop culture about feeding or eating problems that can signal to you disordered eating or potentially developing an eating disorder later in life, which is really important to address early on because, as we discussed, early intervention can improve outcomes in these feeding and eating disorders. So you may have heard the term of orthorexia. This is, say, being overly focused on quote unquote healthy eating. And you may wonder, why is healthy eating or eating too many fruits or vegetables or exercising a certain amount of time a day, why would that be detrimental? It can become damaging for someone's life because it may impair their social functions. They become so restricted that they don't go out, or they spend so much time trying to gather those foods or make arrangements outside of their daily work or social lives to restrict to those diets, even though they're not necessarily having weight fall off to a very low weight. They're just very focused on the healthy quote unquote aspect of it. It's difficult to estimate the prevalence of this disorder because, as I mentioned, these following disorders aren't in the DSM, but so there aren't formal criteria, but it's something that signals that something could happen later on. And so maybe you need to refer the patient to therapy or for further workup to prevent something from happening earlier. So some people have also found that it is a form of anorexia if it is related to the undue influence on low weight, or kind of like an OCD because of the obsessive components of it. So this is quote unquote drunkorexia, something that you should also be very cognizant of in transitional age youth. It is when individuals will purposely restrict food in anticipation of having alcohol later in the day. It's something that increases the risk for vitamin depletion or dehydration, because as you all know, if we're not eating before drinking alcohol, it puts you at greater risk for intoxication and for those detrimental consequences with alcohol. It can be scary for individuals because not only are you more likely to be dehydrated, have like say your B vitamins depleted, but it can make you drunk a lot faster than you would expect and put you at risk for risky populations. So a question I've heard is, how do you know who to screen for this? I think we've heard a lot of individuals who seem like they're perfectly well functioning say that I'm not going to eat this or XYZ because I want an extra glass of wine. Is that drunkorexia, or is that concerning behavior? You know, so it's a fine line, but it's something that I think that we should really screen for in high risk populations, those populations who are at risk for going out and drinking several drinks or binge drinking at night, who really want to compensate and who could really put them at risk for that really heavy intoxication that I just talked about if they're not eating anything during the day. So those populations, as you can imagine, are college age populations, transitional age youth, although that is not an all-encompassing list as at all. As I mentioned, all these disorders can lead to a future eating disorder, but also potentially an alcohol use disorder. And I would just encourage to at least have a small snack or something to not have those consequences happen. So this one is quote unquote Bigarexia, or in some ways, you know, using anabolic steroids or with an overemphasis on muscle building that's been termed in the lay media. It's a preoccupation with muscle building, and there is a DSM diagnosis of body dysmorphia, where individuals will feel that they see something different in the mirror or are preoccupied with a certain area of their body compared to normal individuals, like an over excessive focus on it. And there is a term under there in the DSM of muscle dysphoria. This may lead from going from excessively working out or trying to muscle build or weight lift to compulsive exercising or abuse of anabolic steroids, as I mentioned. One study found that 16% of males in the US in that transitional age youth range, 18 to 26, had tried performance enhancers, and 3% had tried anabolic steroids. So in some ways, this kind of overlaps with the substance use disorder, like we saw with the alcohol use restriction disorder for eating and with eating disorders. So some signs for this may be mood swings, because that's a side effect from anabolic steroids, gynecomastia, which is where males have a buildup of breast tissue, altered lipid levels. They'll have a low HDL, which is the good cholesterol, and a high LDL, which is the bad cholesterol, which is also a sign of possible steroid misuse. Polycythemia, which is elevated red blood cells, once again, a consequence of the steroids as they're trying to build up those red blood cells so that way you can work out more. And acne in characteristic parts of the body, such as truncal, chest, or back areas. So just something to screen for in our transitional age youth. And something I thought was interesting is they have researched trauma and eating disorders as well. But something that I read about you know, this excessive muscle building in males is that it may be sometimes in males who have had a problem in the past with bullying or a history of trauma, trying to, you know, now counteractively build themselves up or make themselves seem stronger. So obviously that's not a telltale sign, but something I thought that was interesting to point out. Okay. I also thought this one was very interesting, but is actually somewhat common, is the misuse of insulin in type 1 diabetics. Quickly, just a refresher, but type 1 diabetics do not make any insulin as opposed to type 2s. So if they don't inject themselves with insulin, they don't have any insulin, which can be manipulated by the individual to try to avoid weight gain in certain situations. However, it can also lead to some very life-threatening medical complications, such as diabetic ketoacidosis, DKA, because their body's not making any insulin, and they can very quickly, in less than a day, go into shock and be admitted to the NICU. I also thought it was interesting because I read that diabetics may be at increased risk for eating disorders, just point blank, because they have such increased awareness on diabetes education with food, insulin control, calories, sugar content, and it puts this undue influence on their life that maybe they wouldn't have if they didn't have a diagnosis of eating disorder. And I just wanted to point out that the DSM-5 does classify withholding insulin as a form of a purging compensatory behavior, because you won't gain weight if you withhold it. And it could technically be classified as bulimia nervosa, a type 1 diabetic withholding insulin, if it meets that criteria we talked about at least 1 time a week for 3 months. So that was my broad overview of some concerning eating behaviors and the DSM-5 criteria for eating and eating disorders, besides pica and rumination, which I mentioned were more associated with developmental disorders. But I just wanted to give a little history on eating disorders to see where all this comes from with this increased prevalence. Well, eating disorders have been documented for quite some time now. There were reports of disordered eating behaviors back from ancient Egypt, the Renaissance times. And back then it was kind of with themes of spiritual fasting or self-discipline or power. And these females, kind of like Catherine of Siena, who I have pictured on the right, were seen as these all-powerful women because they didn't need to eat, which kind of brings into our light today. Sometimes eating disorders seem kind of glamorized. And I think it's interesting that back then, even then, they were in awe sometimes of these women who didn't seem like they needed to eat. In fact, the term anorexia mirabilis, that translates to holy anorexics, meaning like amazing or remarkable, or the term they gave it was something to almost be respected. It wasn't really until the 17th or 19th century that eating disorders were first seen as mental health disorders, when some physicians back then would document cases of case reports really of patients with eating disorders that would not eat despite their health being harmed. And at that time, it was coined anorexia nervosa, which translates to nervous consumption, like that fear of eating, rather than this mirabilis or holy or remarkable or amazing for not eating. By the 1970s, eating disorders really became more well-known, especially in the Western world. This was something that had a variety of factors, both from increasing obesity from the Western diet, as well as pressure for thinness from the media. There were celebrities like Karen Carpenter, who was a singer who died from anorexia, who helped raise awareness for it. And this really started sparking in the 70s, at least in the US. And you can read that bulimia nervosa after anorexia became diagnosed in 1979. And then binge eating disorder was first mentioned in the DSM-3, the last of those that I mentioned earlier, formally in the diagnosis, besides Rfid and Onset, which was obviously revised from Ednos in 1987. So bringing this back to other cultures. So when did eating disorders and all this interesting history prevail in Asia, since this is a continent and countries with such varied history and long history, dynasties and centuries back? Some of the first documented descriptions of eating disorders were way back in Japan in the 16th century. I'm not going to try to pronounce that, but like the Fushoku Byo was coined by Japanese physicians of females not eating for avoidant reasons. So we're starting to see physicians document females not eating for avoidance or nervousness, rather something that was like witchcraft or something to be respected back from the medieval times. Eating disorders became more recognized in Asian cultures approximately around the 1980s, which was, if you recognize from the last slide, about a decade or so after the Western world, which makes sense if you think about it in terms of development and the theory of Westernization contributing to eating disorders. Singapore, one of the most economically developed countries in Asia, was leading most of the diagnostic traction at that time, catching up to the Western world. And in the 1990s, there were more Chinese studies on eating disorders becoming more prevalent. And there were reports of atypical anorexia in China, with feelings of lack of appetite and bloating being typical complaints for not eating and losing weight, as well as increasing reports of the typical anorexia that we typically imagine, as I've presented, with the fear of weight gain and wanting to lose weight loss. So kind of interesting about the different reports with atypical anorexia in Asia, feeling like you don't want to eat because you're feeling bloated or not having an appetite. Just something I want you to keep in your back pocket. So that brings us to now, after we've ran through the 70s and 80s and 90s and medieval times, to the prevalences now. So this is a diagram I made on the prevalence rates of eating disorders in Asian Americans in the US, and also Asians as well as an all-encompassing group. And so we can see here specifically for binge eating disorder, as I mentioned before, it's a little interesting as in binge eating disorder having a fairly more equal gender ratio compared to other eating disorders. And in some studies, I found that Asian Americans had even higher rates than their white counterparts. And it's really hard to study because these studies on epidemiology, it's a single study and then they'll generalize it. But I think what we can see from these slides here is that overall eating disorder prevalences in certain highlighted studies are equal to, if not higher, for Asian Americans as their white counterparts, as I mentioned. You can see similar rates for bulimia nervosa, for binge eating disorder, and we can see the overall prevalence over here as well. And trying to expand this to other groups as well. In this study, for Latinos and African Americans, it was even higher than their white counterparts when you lump all the eating disorders together with binge eating and bulimia. Although in anorexia, we still see maybe higher prevalence in whites than some other groups. So this brings me to wonder, as I've alluded to earlier in this talk, if disordered eating behaviors and some of these rates that I showed in that diagram before are, slightly lower, about the same, but we're talking about, binge eating being higher in some cases, anorexia being lower, but then disordered eating symptoms. But we get this picture of, white females being the typical picture of eating disorders. What's going on with that? There's a lot of challenges in studying eating disorders or any psychiatric illness in non-white groups. For example, in Asian populations in particular, 25% of the population in Asia is classified as underweight by BMI standards of being less than 18.5. So they've actually taken out the DSM criteria of needing to be at a certain exact BMI, as they did in DSM-4. But it begs the question that if we're going by BMI and a fourth of this population is already underweight, how are we going to classify what's a quote unquote low weight? Just something to consider. And we could, flip this. I don't have the data and statistics on other non-Asian minority groups, but we could say, if those groups are underweight or normal weight or overweight, that's something that we have to consider when we're using such a vague term such as low weight. What is it for that group? In fact, the World Health Organization has more stringent obesity cutoffs in Asia, meaning that while you would have to be a certain BMI in the US to be considered obese, in Asia that's less, because such a large population of Asia is underweight that they have more stringent cutoffs, but they don't set those for being underweight, which makes it really challenging to diagnose eating disorders and consider what is underweight. And then moreover, once again, just considering the body habitus as we have for this bullet point, Asians have more central fat deposits, meaning accumulation in like the truncal area, the stomach, than their white counterparts by studies, which is also concerning because there's been studies showing that having more of that stomach or truncal weight is more detrimental for cardiovascular risks than, say, if it was carried in the limbs. And then also challenges for studying eating disorders in the Asian population is that there may be a stigma towards mental health patients and eating disorders in the context of Asian culture, not having the awareness of what it really is, or not utilizing mental health services, leading to it partially possibly being underdiagnosed and leading to the lower prevalence, although there's similar disordered eating rates. Alrighty. So that begs the question, do eating disorders present differently clinically in terms of their presentation in Asian Americans compared to their white counterparts? So one study found that Asian American females experience similar, if not higher rates of body dysfaction and or disordered eating and functional impairment from eating disorders, as I've referenced throughout this talk. There were a couple studies that supported that. And as I mentioned with the slide with the diagram about atypical anorexia, Asian Americans may present with more somatic complaints of feeling full, feeling bloated, rather than having psychological distress, such as this overbearing drive to lose weight. Although that is something for anorexia that needs to be highlighted, but that doesn't mean they can't have disordered eating without that undue focus on weight loss that I pointed out for anorexia and bulimia nervosa. This leads to a possibly lower diagnosed prevalence of anorexia and bulimia nervosa in Asian American children and adults. But some studies have even found higher rates of binge eating in Asian Americans, yet lower prevalence of binge eating disorder, possibly because as we pointed out earlier, with binge eating disorder, you have to report this distress from binge eating. So it begs the question, maybe is there something in Asian American culture that makes it more acceptable to binge eat, or is it holidays or something that drives them to binge eat, and then they don't report distress from eating until they feel uncomfortably full? And it's also very difficult to assess because Asian Americans are such a diverse group, and when we lump them all into just Asian American, there's Southeast Asian, there's East Asian, there's a lot of different groups with a lot of different cultures, and it's hard to study when we lump them all in at once. So broadening out, what stressors may contribute to an increased risk of eating disorders in our minority youth? A lot of studies have shown that it's hard because with acculturation, we've mentioned these different, standards for maybe not standards or criteria for classifying obesity in Asia itself. And now we're in America, and now it's Western diet, but you're eating Asian diet at home. So a lot of studies have posited that possibly acculturation is something that has contributed to an increased risk in our minority youth. One study in British schoolgirls found an inverse relationship between acculturation and body dissatisfaction in disordered eating. And they found that there was a higher rate of eating disorders among second generation, which means if your parents were immigrants and you were born in the US, compared to first, which is if you were the immigrants, or third generation, meaning your parents were native born. They think that this could possibly be because of that acculturation and the stress that it places on these adolescents. Continuing on, there may be different cultural factors affecting reporting of symptoms. As I mentioned before, with Asian Americans being found in studies to report more bloating or loss of appetite rather than feeling like they need to lose weight. And certain eating disorder questionnaires or screening tools can be culturally biased. For example, I mentioned before that in the previous slide that binge eating was reported to a higher extent in Asian Americans, yet there were not always diagnosed binge eating disorders. And maybe it's because some of these questions, these are pulled straight from the Eat 26, a questionnaire. I avoid eating when I am hungry. I have gone on eating binges where I feel I can't stop. Certain individuals may agree, but they may not be eating disorder based. Something I found very interesting in the Asian American population when I was doing some reading about this was that Ramadan, something common in a lot of Asian cultures. Maybe those youth or individuals are, used to fasting for a prolonged period of time. So when they answer these questionnaires, it's something they're used to because they're going, 12 hours without eating for Ramadan with not eating during the sunlight. And so we have to take into account the cultural basis of some of these questionnaires, which the DSM has tried to do with the cultural formulation when interviewing patients. So that brings us to treatment and assessment. As I've mentioned before during this talk with the statistics now, there's a higher utilization of eating disorder treatment in whites versus Asians. I've talked about the challenges, including cultural stigma towards mental health care, and how it might be difficult kind of with that acculturation piece at home, because emotional regulation and discussing things related to mental illness for the child or the adolescent or the transitional age youth at home is really influenced by culture, which may not be aware of this disorder because they didn't have education about it back in their home country, or just because, you know, in their culture, you know, youth and their parents have a different relationship and they're supposed to have a different level of respect. I mentioned earlier before, but the gold standard treatment for eating disorders therapy-wise is family-based therapy for anorexia nervosa. That's a therapy where, you know, the parents really drive the adolescents' change in weight and eating behaviors. Adolescents don't necessarily have the best insight, so it really relies on the parents to do that. And it may be hard when, you know, parents have difficulty expressing their cultural backgrounds in a language that's not English. This goes beyond just Asian American individuals. This can go for any non-white, non-English speaking group. It's really hard for them to communicate with therapists and explain and be able to incorporate family-based therapy, the gold standard for anorexia nervosa. And specifically with the Asian population, you know, there's been studies on how it's a very collectivistic society where they are a unit, and it might be difficulty for them to accept so much help from a new quote unquote expert who's a stranger into their family backgrounds. So this also brings into how can we properly help these transitional age youth, even with these barriers to treatment, to be able to get better depending on what eating disorder they have. I think that it's important, you know, making the initial assessment medically to use blinded weights, which means that the individual does not see their weight, whether that's, you know, they're weighed backwards on the scale or you cover the weight so only the nurse can record it. So that way there's not this undue influence on weight and number. As we mentioned earlier, that can cause stress even in, like, say, that we mentioned earlier within diabetics, having that, you know, too much focus on food and weight and numbers. Also, it's important to weigh in gowns after the patient uses the restroom. Eating disorder patients are very smart, and, you know, you'd be surprised sometimes what they can do with manipulating their weight. A heavy jacket, if you're in the Midwest or, you know, the Northeast, can very easily add like 5 pounds, which is very critical when you're measuring weights daily, or, you know, a big pair of boots. So make sure to do that. And after using the restroom, there have been cases where patients have tried to water load and drink a lot of fluid before they get weighed to add a couple extra pounds, because it makes a difference when you're tracking that weight, say weekly. So that brings us, I'll talk about it in the next bullet, but also the specific gravity in urine to see how dilute that urine is after you get it. Were they, you know, is the specific gravity 0? That's something that should make your red flags go up. As I mentioned before, I mentioned growth curves for transitional age youth, maybe males who are still growing, or, you know, kids or adolescents who should be going up, not just falling off or even plateauing. And vitals, watching for bradycardia, that slowed heart rate, or hypotension, low blood pressures. That's something, if it's consistently concerning, could be reason to hospitalize. And other labs you want to consider just to rule out things are thyroid, which can have abnormalities in eating disorders, but also just ruling that out as a reason for weight loss. LFTs can elevate in malnutrition, the liver function tests. Lipids, interestingly, similar to what we talked about with excessive muscle building and steroid use, can have high, you can have high levels of the bad cholesterol and low levels of the good cholesterol. And lipids overall can just kind of elevate, which you might wonder, why would your lipid levels elevate in, you know, eating disorders, particularly anorexia, if you're not eating enough? And it's actually because your cells are breaking down because you don't have enough nutrition. So back to biology and biochem, your cells are breaking down. Those phospholipids in the cell membranes are getting released. And so that's why sometimes you can have very, very medically frail individuals who have high cholesterol levels, because they're not eating enough and their cells are breaking down. Amylase can also be a good version for seeing if someone is self-induced vomiting. And similar to that, in just general labs, your sodium bicarb from your basic BMP or CMPs. And a DEXA, because sometimes these individuals can eat so little that their bones begin to deteriorate. And EKGs if there's any heart abnormalities from hypokalemia, hypomagnesemia from low potassium and magnesium, or just the heart muscle wasting away because there's not enough nutrition. So I'm going to briefly talk about medication, just because I know we have a variety of providers here, but I wouldn't be doing my due diligence if I didn't cover this a little bit. There are 2 FDA approved medications right now for eating disorders. That's fluoxetine or Prozac for bulimia, and Vyvanse or lisdexamfetamine for binge eating disorder. Those are the only 2 with FDA approvals. And these are typically at a little higher doses than you would use for, say, like depression for the Prozac or fluoxetine. And there have been studies showing that if you cannot tolerate fluoxetine, you can try another antidepressant. It's just the FDA label, meaning that, you know, the drug manufacturers used fluoxetine for this reason, and centered the studies around this reason to try to get the approval. There's also been medications such as topiramate or Topamax for binge eating disorder showing some weight loss, but it's still really important to go into therapy, which I'll get into the next slides, as well as naltrexone, which has been used for, you know, opioid use disorders. Some of you may have heard about it for, you know, helping patients with cutting or stopping cutting and self-harm. Basically what happens is naltrexone reduces rewarding aspects in our brain, and that's why they think it may be useful to reduce binging and binge eating disorders, although that's also not FDA approved. And there has been some thought of olanzapine for anorexia nervosa. And the thought behind this is some people argue that anorexia is a delusion or a psychosis, and they have such poor insight into their disorder, they're almost psychotic, and olanzapine could be used to do this, and to treat this. And there are studies showing some weight gain with anorexia nervosa, but I just wanted to stress that it's really important to also treat with therapy, because if you just use a medication to treat or cause weight gain and we don't treat the therapy, relapse is going to be really common. And I also personally think that the argument for anorexia being kind of a delusion is flawed in some senses, because there's arguments saying that, you know, if patients were really delusional or psychotic, they might insist that, you know, no, I weigh like 200 pounds. There's no way that I weigh 70 pounds, but they know exactly how much they weigh. So that's my little hesitancy with using olanzapine for anorexia and the argument that anorexia is a delusion or a psychosis. Some patients also get really, really anxious when they're eating food or in that weight restoration or other aspects of eating disorder treatment. So you can use some anxiolytics, boost bar, something to help with the anxiety as they're going through these really intensive treatments. And I just wanted to point out that there is an antidepressant bupropion, Wellbutrin, that's contraindicated in treating those even previously diagnosed, as well as currently diagnosed with bulimia or anorexia nervosa, because it is known to lower the seizure threshold secondary to electrolyte imbalances, which are very common in eating disorders, thus necessitating us getting labs, as I mentioned before. So just something that if the patient insists, or if you inherit a patient on bupropion who has documented eating disorders, just document in the ER, because it is a boxed warning, and we want to make sure that the medical legal risk is protected. Sorry, I have about 3 more slides, but I just wanted to mention briefly that even with all these treatments, anorexia nervosa, particularly, the mainstay of eating disorders is therapy as treatment and food being medicine for anorexia nervosa. Particularly, there's no med that's magically going to fix anything. It really should be focused on nutritional rehab and weight restoration. And then I just briefly wanted to highlight some of the various forms of therapies, as I just mentioned. It's more therapy that is the long-term treatment of these eating disorders, because we can try to help patients stop binging, or try to help patients gain weight, or do any of that. But if we don't treat the mindset behind it, there's a lot of relapse. I mentioned that family-based therapy, particularly for these kids and adolescents, is the gold standard. Having the parents drive the feeding and weight restoration at home, because a lot of these kids don't have great insight. Another name for it is the Maudsley method. Exposure-based therapy, or CBT, for eating disorders is another way of doing it. Exposure can be really good for all eating disorders, but particularly Rfid, when you have those fears of certain foods. I've heard of people saying to gargle if certain textures or liquids bother them, or fear foods to gradually reintroduce. DBT, or dialectical behavioral therapy, for kind of emotional dysregulation. That's something that's kind of linked to binges, which have been found to be very impulsive in certain individuals. So using the skills of DBT to try to kind of hone that in. And IPT, or interpersonal therapy, has also been shown to have some efficacy, because some individuals will go to these disordered eating behaviors when there's interpersonal conflict in their lives with friends or family, and learning how to regulate that aspect. And so just very briefly, sometimes it necessitates, when treatment is not there, to refer to a higher level of care. There can be intensive outpatients, partial hospitalization programs, residential or inpatient units. From the left to the right, that goes from least restrictive to most restrictive, if we feel that, you know, patients' vitals or weights or labs are not there and they need a higher level of care. Always have a low threshold for that, although insurance can play some issues with getting patients the care they need with eating disorders, unfortunately, or restricting the time there. So with that, I just wanted to see if there were any questions, and my references, if anybody needs any.
Great, thank you, Dr. Tai. I have a few of my own, but I obviously want other people to chime in if they want to. There's nothing in the chat, but is there anybody out there who has a question they just want to jump in with? Oh, I hear. Nope. Okay, well, let me ask mine, and then maybe some people will come up with some. I was just curious, you were talking about BMI being used, and of course that's really easy to determine and good for maybe sort of global type things. But what about percent body fat? You know, because BMI can kind of, depending on body type, not be too accurate.
That's a really good question. I haven't seen any like DSM or anything talk about percent body fat. I think that the limitations with percent body fat would be just that I've heard that there's a lot of inaccuracies, even with the different various ways of measuring it. Like some places like do like stomach, or some
Calipers,
places, yeah. So there could be some discrepancies, whereas theoretically weight, if you do weight gown after restroom, it should be accurate or same time of day, but who knows? But that's very interesting. And I think that could be an interesting, that's definitely a good way to think about it. Yeah.
And then it just made me think of too, and this is from experience of knowing someone who is a male who was anorexic in the early 80s. So it was pretty early on in understanding things, especially as a male. And he was an athlete. And I've understood that, especially among endurance athletes, there's a lot of anorexia. And in his case, I guess he wasn't quite transitional age, but men do develop later physically. And he had growth issues because of it. And I didn't know if you came across anything to do with that.
Growth issues, meaning like for adolescents in general?
Yes, he had, right. He was so poorly, had such poor nutrition, it stunted his growth.
Yeah, I mean, that's definitely something that can happen. And I mean, unfortunately, being that like you only grow during a certain amount of years, I mean, when you're having nutritional deficiencies, that's definitely gonna limit those limited years already. I know, for example, it's kind of related, but like for females or males who have problems with DEXAs or bone demineralization, they say that, you know, you can keep building that until your early 30s or late 20s. So there's some more time for that to at least kind of maintain or build it back up. But with growth, it's really those years, which is why it's so important to intervene early.
Alrighty, and before I ask for any more questions, I'm just gonna, well, no, let's do that first. Is there anybody out there who has any more questions out in real world? No? Okay, well, that's actually good because we have a few minutes in that way. I didn't know if either Angela or Alexander had anything they wanted to say just last minute as far as CMEs or who to contact with any issues or anything like that.
No, regarding CEs and CMEs, I just shared the link in the chat again. Thank you, Dr. Tai, for presenting. If anybody has any questions regarding the CE or CME process, please feel to reach out to me directly and I'll help you through that process. Thanks.
And there was a comment that just dropped about having not so much a question as just a comment that they feel that eating disorders are often overlooked.
Yeah, definitely. That's why I kind of tried to highlight, you know, some of those disordered eating symptoms that aren't in the DSM, just because I think catching it on early is really important as they can lead to much bigger issues.
And I was just, since we have a second and people are clicking on these links anyway, so I want to keep everything sort of open for a few more minutes also, unless there's other questions, is I was really interested because I know, again, just from being my age, and like you said, Karen Carpenter, I was around, you know, and just a young person with no interest in any of this. And it was really, society as a whole seemed perplexed. And it was interesting to hear you talk about how so many hundreds of years ago it was discussed in the literature. And I was wondering how much it had to do with just the human condition in general, if this is even answerable. How, I mean, you go back far enough, food or eating was a day-to-day endeavor, and how much of this has to do with being able to control the fact that there is extra food to be had by a large portion of human society now.
Yeah, I think it's hard. I mean, we don't know the data from, like, you know, the
Right.
medieval times, but they did say that it was, you know, some of the intentions behind it then were partly because, you know, these females were seen as whole, like it was very common for women in the church to restrict because they were seen as these miraculous people who didn't need to eat. So it was very interesting. But stemming back, I remember reading in some of the history of all this, like what you said, the excess of food, it was very, like, if anyone gets the reference, like Hunger Games, like there were some reports of like people in like ancient Egypt who were very wealthy and would cause themselves to vomit like in the Hunger Games just so they could eat more. So it's a little bit of like, you know, what we see even now with like the restricting for reasons of power or for control or feeling like the excess of food. And then there were also like reports of people like just, you know, saying it was witchcraft. So kind of all over the place, kind of related. And then obviously witchcraft is not, but lots of theories.
Okay, thank you. And also I know Dr. Silverblatt, and because Dr. Kanaka is not here, and also Dr. Armio are on the call. I didn't know if you wanted to say anything real quick, I think, before we close.
I would love to say something, and then I'll do, and then Dr. Armio will continue. Well, it's certainly a thrill for me to hear the excellence of the 3 presentations that we had today. What a great job. You picked a topic that is relevant to almost all of our work. And you picked 3 very different aspects of it, but I personally feel I learned so much. I wrote that in the chat, but also, I just want to congratulate you for impressing all of us and really impressing me. And I look forward to hearing from more residents, and I also look forward to working with all of you. Thank you so much. And Nick, thank you so much for a great job getting this together through the Medical Society, Psychiatric Medical Society. And we can't do anything without Angela. So I want to thank Angela for everything she did to get us going. This would not have happened without you, Angela. Thank you so much. Yes, thanks, Molly.
Yay.
Applause, applause.
Virtual applause.
Yes.
And Dr. Armio is our president, and she is attending this on her vacation time. So I didn't know, Dr. Armio, if you wanted to say a word or two, or if you're indisposed. I kind of.
She said she's having internet issues. So
okay. Well, on her behalf, I just want to say thank you that we get to work with you guys. It's and you know, this is really neat for me too. You know, I do this job. I also have a degree in social work, and so this is all just really interesting to me. And as most of you know, my wife is a psychiatrist, and all this is fascinating and it's really neat to hear. And I appreciate it. And I'm just impressed by, you know, how smart you guys all are. And Angela, do you have anything else, or can we wrap it up, do you think?
I will wrap it up for everyone. First and second and third of all, thank you guys for your participation on this Saturday morning. I know you could be somewhere else, so to have you guys here is amazing. Thank you. Another special thanks to Dr. Bagwell. Always is willing to do any and everything that we ask him to do, but more so just his contribution to his community, to the state hospital, and to us here at UNM that can never, ever go without being announced and thanked and acknowledged. So we totally appreciate you, Dr. Bagwell. And to our 3 presenters, you have made this an amazing experience of putting this conference together. I know I bugged you guys to the last end. Molly, I literally was just begging her, like, please, please, please. And she said yes, without me even groveling. And as well as Dr. Ty and Dr. Animal. And we didn't even talk about this, but Dr. Aurora is actually our upcoming new rural psych chief. So hi, congratulations to her on that, well deserved. But also thank you guys for making this such an amazing conference. We do this every year, so we hope to see you guys again next year. Dr. Jose Kanaka is not in today. He's actually out in Israel, but he wanted to send his love, his best wishes, and also his congratulations to all presenters. So again, thank you to our sponsors, Nick, Dr. Miho. We would never be able to do this without you guys. So we love this collaboration, and we'll continue to plead with you guys to do it again each year. Again, you guys have your evaluation links, so make sure you get those done. The actual evaluation link will close at like Wednesday 11:59 p.m. Your certificates will auto-populate if you are asking for CEs, so make sure you print those certificates, or at the bottom of the certificate there is a place to put your email address. Put that in there and you'll actually receive a email of that certificate. If you are requesting CMEs, we will actually give you those certificates at the close of the evaluation, and we'll email those out to you guys. All right, so if nothing else from Nick, Dr. Aurora, Dr. Silverblatt, thank you guys for having being with us today, and have an amazing rest of your weekend.
And it's great to see all my old friends and new friends. It's very touching.
Likewise.
Great job, everybody.
Bye-bye.